social movement. So now I invite our next awardee, AIOC Shroff Award, Dr. P. Mahesh Shanmugam, for his contribution, both qualitative and quantitative in nature, in the posterior segment of the eye. Over to you, sir.
Good afternoon, and I thank the AIOS for this great privilege and honor on bestowing the C.N. Shroff Award instituted in the name of the pioneer. So this talk will be about vignettes or small snapshots over a career spanning the last 32 years. So it was Dr. Badrinath who introduced me, inducted me to the field of vitreoretinal surgery and trained me, and it's my obeisance to him, and also my gurus, Dr. Gopal and Dr. Tarun. And my obeisance to people who continue to support me, Dr. Ramani and Dr. Janaki Raman of Shankaraya Hospital, who continue to support me, and without whose support, I will not be where I am. Though the award is given in my name, it's actually the team. Though the idea may have originated in somebody's head, but it's actually the team. Without the team, nothing works, and it's thanks to my team as to what we have been able to achieve so far. Lastly, thanks to my family, without whose support I will not be where I am, and particularly to my wife, who has been standing by me over the last so many years. So one of our strengths is in cost-effective innovations, and let's start with the AIOS itself. So it was we who showed that we can use mundane devices which are lying around in the house, like the handycam, to image the fundus in the era of very expensive fundus equipment. So this we did innovate in 2006, and we got the Rangachari Award for this in 2009, where we put a torchlight on the handycam, and we were able to do an indirect ophthalmoscopy with this device. And these are the images which we could obtain with these devices. And subsequently, we went on to make the indirect ophthalmoscopy with the mobile phone. And these are some of the images with which you can achieve with the smartphone as an indirect ophthalmoscope. Then we went on to create a direct ophthalmoscopy with a smartphone. So this was about 100 rupees LED bulb and a battery, and we were able to make the smartphone as a direct ophthalmoscope, and these are some of the images of the mobile phone as a direct ophthalmoscope. Recently, we did a study comparing this particular device, where we had spent about 100 rupees to create this device, versus the commercially available devices, which cost upwards of around 20,000 or 15,000, and found that our device actually equaled or surpassed the other commercially available devices in diagnosing diabetic retinopathy. Next, we went on to pediatric fundus imaging, which is a burning issue. We need less expensive equipment to image the fundi of infants, particularly to decrease the burden of retinopathy upon maturity. And some time back, we found that you can use a nasal endoscope to image the fundus, and this we did publish. And you can see the images of the retina taken with the nasal endoscope, and this is the gonioscopy, which can be done with the nasal endoscope as well. Of course, it's difficult if you were to make an equipment out of the nasal endoscope, it costs about 150 to 200 times less expensive as compared to the commercially available devices right now. And naturally, I am unable to get any companies to be interested, or industry partners to be interested in making these devices. I hope sometime in the future we'll be able to create one out of this. Moving on to another innovation. So we know that polarized glasses do improve the vision. So this gave us a thought as to see if polarized glasses can improve vision beyond the best corrected visual acuity of patients with multiple retinal and optic nerve devices. There's one such clinical example. This is a 32-year-old lady who had a peripapillary cavernous hemangioma and had a subretinal hemorrhage. We displaced the blood and with anti-VEGF as well as gas, and then subsequently did photodynamic therapy. So she cleared, but then she had only about 660 vision. So you can see that she's struggling to read. She tilts her head this way, that way, and whatever you do, she is unable to read. Then we put on a circular polarizer in front of her. You can see that her vision instantly improves from 636 to 66. So this gave us a thought process that a circular polarizer, this is not a regular linear polarizer, but it's a circular polarizer, showing that we can improve the vision of patients beyond best corrected visual acuity with a particular polarizer. So once you take it off, you can see again she goes back to bending her head this way, that way, and struggling to read what she was able to read with this, and she in fact demands for this particular lens. So we did do a study, and this included patients with retinal diseases, optic nerve lesions, and optic nerve pathway lesions of various pathologies, diabetes, RVO, AMD, PFT, and such, and found that in about like 80% of the patients, we were able to improve the vision one line beyond the best corrected visual acuity, and in about nearly 50% of the patients, we were able to improve vision by about 2 lines, and 20% more than 3 lines of vision. And in fact, we did receive a patent on this particular innovation of using the polarizing lens in optic nerve as well as the retinal diseases recently. Moving on to photobiomodulation. Photobiomodulation is a treatment adjunct which can be used in patients with retinal diseases such as age-related macular degeneration, diabetic macular edema. We innovated this very simple device of a custom-designed yellow-green filter, and like the patient will gaze at the sun through this filter for a particular period of time. This was how it was done for a particular period of time in a day. And this is a classic patient many of us come across in our retinal practice. We have done everything possible, but still the patient continues to have diabetic macular edema and we are unable to help them. So here you can see that with this photobiomodulation, what happens? The macular edema went down considerably just by staring at the sun through this particular device. And did we harm the eye or did we harm the macula by asking the patient to stare into the sun? But the visual field shows that there has been no worsening of the central visual field. In contrast, the untreated eye continued to worsen or remain the same, whereas the treated eye, the macular edema decreased. And once we stop the treatment, you can see the edema coming back, indicating that it's the treatment which works in decreasing the edema. So a very small study we did. In about like 11 patients, we found that 70% of the patients, the macular edema decreased when we added the photobiomodulation to the existing treatments or as a standalone treatment. So we are in the process of finding alternates because vagaries of the sun, sometimes it can be cloudy, sometimes it can be very bright. So we are trying to find digital devices which can replace the sun and use photobiomodulation as an adjunct to existing treatment. Similarly, we have innovated in the surgical space. So here we have used an illuminator to localize the break during a scleral buckling surgery because the novices find it very, very difficult to localize the break precisely, and the illuminator precisely is able to localize the break. And we have also created an illuminated cryoprobe, again a cost-effective invention, like you can make this yourself. Once again, this improves the precision of the treatment as well as the localization of the retinal breaks. In fact, we have a paper on the recent innovations in scleral buckling, thereby making it popular once again. Coming on to academic space, we created this RetNet India, which was founded in September 2005. That was the first digital-based discussion forum, and subsequently, of course, we have many of these. But this is what we started with in 2005, which had members all across the country and other parts of the world as well. Pre and post Shankar Nethralaya, around 1/3 of the publications were during Shankar Nethralaya, and subsequent 120 publications or so subsequent to the time after Shankar Nethralaya. And we have trained about 75 fellows over the last 15 years in Shankaraya Hospital. And what do they see? They see that with vitreoretinal surgery, there is always a hope. So we do stage 5 ROP surgery, a closed funnel, a closed vitrectomy, but then this is one of the rare situations where we had to do an open sky vitrectomy because the corneal opacity was there, and in addition to that, there was a stage 5 ROP underneath that. So we opened the cornea, removed all the scar tissue, and allowed the traction retinal detachment to reattach. So this is what our fellows see and learn, knowing that there is always hope with the vitreoretinal surgery. So that's the open sky vitrectomy and then closing the thing. And this is an end-stage diabetic eye disease. This is a one-eyed patient with extreme diabetic traction retinal detachment or a combined retinal detachment with absolutely no visible retina. And with very meticulous surgery, we know that we will be able to reattach this retina as well. So it's a bimanual dissection of all the fibrous tissue. You can see that there is something resembling the retina underneath all this fibrous tissue. So there's absolutely no cleavage plane between the fibrous tissue and the retina. And post-dissection, we left this eye with perfluorocarbon, and this is what we began with, and this is what we ended with at the end of the surgery. And there is another quadruple amputee. This is the only eye remaining, and this was after removing the synechia. We did an open sky and dissected all the scar tissue from the anterior chamber. And what you find is, like, during the process, you find the whole retina prolapsing outside. You put it back and with viscoelastic, and the curve process, we went back inside to find a closed funnel retinal attachment, which we opened up to reattach, and this gentleman still retains about 3/60 or 4/60 vision, and this is the only eye. And as I mentioned, he's a quadruple amputee. He's a war veteran. You can see that the retina has gone back despite a fold around the optic nerve. We do dabble with the tumor-related retinal attachment. This is a retinoblastoma in a one-eyed child with a recommended retinal attachment, where we're left with no other option but then to resect the tumor and then reattach the retina. So the journey continues, and thank you once again for this great honor and patient listening. Thank you so much.
Thank you, sir, for this wonderful